My pleasure to introduce Dr. Frederick Freitag. Dr. Freitag was born and raised in Milwaukee, received his medical education at the Chicago College of Osteopathic Medicine in Illinois, completed his residency and family practice at Brentwood Hospital in Ohio, and received specialty training in headache medicine at the Cleveland Clinic. He's been a primary investigator on over 200 clinical trials, published over 150 peer-reviewed articles, and holds a certificate of added qualification in headache medicine from the National Headache Foundation and certified in headache medicine by the United Council on Neurologic Specialists. Thank you, Dr. Freitag.
My pleasure. Thank you very much for having me here today. So, as far as disclosures, you kind of said it all. I've been doing headache medicine for 32 years. There are no drugs that are approved for the treatment of headache in the United States that I have not done clinical trials on. And there are very few other drugs that are available for treating headache that I haven't done clinical trials on. So we'll just leave it at that. And so I have no favorites. No favorites. Okay. I have a long connection to the magnesium healthcare system, going back 68 years. My mother was a nursing student in 1949 at the old St. Agnes Hospital, when the nuns still ran the place. They don't run it anymore. No, I don't know. They're gone. Okay. So,
They're all still alive.
my training being in family medicine, one of the things that, always concerns people when they have patients come in, that's new to them, and they come in, they got a complaint of headache, is, the short hair starts to go up because most people don't have a lot of training in headache medicine. And so they say, well, we've got to worry about, bad stuff. Well, this will kind of help you give some clues as to when to recognize bad stuff. Bad stuff is when somebody comes in with a headache and they are sick. They've got a fever, they've got a coexisting recent onset medical illness, they have an oncologic diagnosis with potential for metastases, and it's new. The headache is new for them. If they had headache before, it is a different headache from what they have had before. It's not the same. You also have the short hairs go up if they're older getting headache. My former partner, Seymour Diamond, used to say that headache is not a DRG diagnosis related groups. It's an old Medicare term, okay? You don't see headache develop for the first time in older individuals for the most part. So when you do, you ought to be suspicious. But overall, if you have a patient who comes in who has a relatively stable history, they could make sense of making a migraine diagnosis of it. They've got a normal interictal examination. You have less than 0.2% chance of finding anything outside the norm on neuroradiological studies. So that includes white matter lesions, okay? That includes arachnoid cysts. That includes nasal sinus disease. So when it comes to scanning, when do we do scans? Well, you do scans when there are changes, when there are things that are suspicious. You suspect that there's a change in headache or there's an organic cause for the headache. You want to think about getting a scan. If they have new onset of seizures associated with their headaches, or if on your examination they do have focal neurological symptoms. Now, one thing that's not a focal neurological symptom is increase in headache doing a Valsalva type maneuver. Everybody's headaches get worse. Everybody with migraines headaches get worse when you do a Valsalva type maneuver. So bearing down, okay, doesn't mean anything that increases the headache, so don't worry about that. So what should you do? Well, technology has improved dramatically over the years for CAT scan as well as MRI. And so it used to be that we would definitely say, in the ED, you suspect an acute subarachnoid hemorrhage, you do a CT scan, or if you suspect nasal sinus disease, And for everything else that they come into the office with, you probably do an MRI, you're thinking that they got some kind of space occupying or other vascular lesion, or you're just being careful. But you know, nowadays with the quality of CAT scanning and the ability to see the posterior fossa so well on sagittal views, you know, the demand to move to MRI for everybody's headaches just isn't there. Yeah, you really do need an MRI to get really good, you know, characterization of a true Chiari malformation, but you can get a lot of information by a regular CAT scan. The other question is, do we do contrast dye on these individuals? Well, for the most part not unless you are truly suspicious and you think that there's you find a lesion on scan that is a white matter lesion, could be, is it MS active, is there a tumor there? You probably want to do contrast enhancement on MRI in that situation. MRAs, if you're truly suspicious, good evidence to suggest they got vascular disease, perfectly appropriate, good quality. CT angiography is equally as good. It's a all-comers kind of thing as to which one you prefer. Biggest issue is the dye and the radiation. MRVs, if you suspect pseudotumor cerebri, increased intracranial pressure, and they've got some other, they got characteristics findings for it. And if you're suspicious that they have some narrowing of their transverse sinuses draining venous circulation, and you want to look for that, then you probably want to get an MRV. But otherwise, you usually don't need to do one. The new dyes with MRI that they're using nowadays with gadolinium have drastically reduced the risk of toxicity from repeating contrast enhanced scans, so there's not the worry that there was 5 years ago with people developing neurotoxicity from having repeated scans. Now this is the bane of everybody, okay? These are what are called white matter lesions, okay? And based upon the radiologist, you know, they can put the fear of God into you, okay? Because they tell you, well, that looks like small vessel vascular disease, okay? And this is a 28-year-old who's got episodic migraine headache. You're not going to run out and do an angiogram on this person, all right? We really don't know what these white matter lesions are, okay? We don't have any really good pathologic evidence, okay, for what they are. And the crazy thing is that they go away. They aren't static. So don't get crazy about them. They have no long-term prognostic significance when you see these small little white matter lesions out in the periphery. Now, there are other white matter lesions that you do see with diabetics and hypertensives and with advanced age. Okay, now that's a horse of a different color. Those do have downstream prognostic effects for dementia in later life. Now, here is a patient with MS. Now, you look at these white matter lesions, and they are one, periventricular, two, they're much larger, much more fluffy than these petite little dots that we saw in a migraine patient. So these are very different. You also can find cuts in the corpus callosum on sagittal view. So these are very different and are easy to differentiate in the vast majority of patients. Sometimes they are harder, and you do have to move on to do additional studies to differentiate causation. So you're sitting in your waiting, you're sitting looking on your waiting room. I want you to tell me what percentage of patients, of people sitting in your waiting room, have migraine. Any guesses? %. When you go home tonight, count the number of houses on your block. Divide by 3. 1 in every 3 houses has a migraine sufferer in it. If you were to put down $2 to win, place, or show on the next patient that comes into your office and says, I have headaches, doc, and you said migraine, you have a 90% chance you are coming away a winner. Okay? Migraine is the most common headache that will present in medical practice. It's not the most common headache, tension headache is, but we'll talk about that. So what is migraine? Migraine is an inherited headache. It probably is occurring because the brain of migraine sufferers is a more hyperexcitable, hypervigilant nervous system than for people who don't have migraine. It's an inherited trait and it has distinct electrophysiological differences compared to people who don't have migraine. And migraine is a complex of symptoms. It's not just a bad headache, all right? Migraine is a whole body disorder. So if people have migraine, that's why they get a headache, and the headache does have distinguishing characteristics in many cases. It's throbbing when it first starts. It's usually severe, does produce interference with activity. It's made worse by doing simple physical activity. Back in the 3rd century BC, a Greek physician told his patients that if they woke up in the morning and they weren't sure if the headache they had was migraine, they should bend over and put their head between their knees. And if it got worse, it was migraine. So simple physical activity makes migraine pain worse. And the typical headache goes on for 1 to 3 days. Shorter in kids, okay? Now, one of the things about migraine is the occurrence of all the other symptoms that make migraine. So when you inquire about migraine in your patients, you have to ask them to tell you about a headache that they didn't take anything for, untreated. Because the other symptoms, the gastrointestinal symptoms, the nausea, loss of appetite, the vomiting, the neurological symptoms, the light, the noise, sensitivity, difficulty with memory, concentration, speech that can occur commonly with migraine, those symptoms may be blunted or not occur when patients intervene and take almost anything for their headache. So if someone has a headache, they start taking Excedrin migraine, all right? Right when it starts. Well, the headache never gets real bad, but it doesn't go away, it goes on for 3 days, and they have no other symptoms with it because the headache never got severe. It only got to a more mild, moderate stage. So we have to always inquire about the non-treated headache. Now, going back to placing your odds, you've just gone through 10 minutes with your patient, gone through 5 different complaints. You think everything is all finished, you got your hand on the doorknob, and they say, oh, by the way, I get these terrible headaches. You ask them 3 simple questions. So, with these headaches, and you're going to, because you're going to pin the diagnosis, little acronym. So with these headaches, do you find yourself more sensitive to light than normal? Yes. Do these headaches interfere with your normal activities? Yes. Do you ever get nauseous or lose your appetite, feel queasy on the stomach when you have a headache? Yes. Answering 3 out of 3, it's a 97% chance the headache you're talking about is migraine. 2 out of 3, it's a 93% chance. If you run the statistics, that's better than the odds for diagnosing cervical cancer with a pap smear. Now, you got a brief answer, okay? You got your foot in the door. You can say, you know what? We're going to have you come back and talk more about your headaches and stuff, how we can do X, Y, or Z in the meantime. So at least get your foot in the door and they feel better about that. About 20% of people with migraines get a distinct neurological warning sign that precedes the headache. The most common of which is a visual warning signal. But some people will have loss of sense of speech, or they'll garble their words. A few years back, there was a reporter at the Emmys who just garbled her talk live on camera for everybody. Okay, that was her aura, all right? Some people have transient numbness, not weakness, numbness with their headache, all right, as a warning signal. The visual ones have a tendency to spread across the visual field, and they can be bright flashes of lights. They can be what's called a fortification spectra. It looks like an ancient European fortress tower with the jagged lines. Now, one of the things about migraine visual auras that brings comfort to you is that migraine auras always have a positive visual element to them. When you have a transient ischemic attack or a stroke and you have visual phenomena, you lose vision. Things go black, okay? There is no sight because those nerve cells aren't functioning. In migraine, those nerve cells are actually overfiring. And that's what causes the visual disturbance. And they see it in the form of a positive visual element, alternating black-white lines, all right? That's one of your real keys. It's migraine and not something more worrisome, because that won't occur with stroke, right? So these auras last about an hour, max, fade out, the headache comes on its heels. The unfortunate thing is, even if you get an aura, nothing really works to stop the headache at that phase. So you have to just kind of be prepared, you know, like the old American Express commercials, and don't leave home without your medicine when you get migraine aura. Now, tension headache is by far and away the most common headache in the whole world, but nobody comes to your office with it. Because, by definition, it's not a bad headache, at least for most people. And by definition, it has no other symptoms with it. It is just a headache. Now, the headache may be 24/7, 365, but it has no other symptoms with it. They don't get light sensitive, noise sensitive, they don't get nauseous, you know, they don't have any of the stuff we see in migraine. So when you see that, it's a tension type headache. Unfortunately, a lot of patients with migraine get misdiagnosed as having tension type headache, especially if they get frequent migraine attacks. And why do they get misdiagnosed? Well, part of it is that 75% of people with migraine get neck pain as part of their migraine, before, during, or after, all right? 2, stress is by far and away one of the most common triggering events for migraine attacks. So, Miss Smith walks into your office and she says, "Oh, doc, I'm getting these terrible headaches." Well, what's going on giving you these headaches? Well, life is just terrible. My spouse is worthless, okay? You know, he's just a piece of, you know, I gotta do everything, all right? You know, and my neck gets crazy by the time I come home from my day of work as a computer analyst, sitting there typing all day, head too far forward, okay? You know, and, well, of course, you know, and I take Excedrin as soon as I get these headaches. So she gets no other symptoms except pain. And so you say, obviously this is a tension headache, brought on by stress, it's all in your neck, no other symptoms? Not necessarily, okay? So be sensitive in looking at other factors, and again, the untreated headache. We also see sinus as a cause of headache misdiagnosed in place of migraine. And the reason for that is where the pain is sometimes, but also a triggering factor. Weather is a common trigger, changes in barometric pressure. Just like your arthritic patients complain about, they can tell you when the weather is going to change, doc, because my joints hurt, okay? Same thing with migraine sufferers. You know, it's also an autonomic disturbance. You know, you have changes in blood vessel flow and blood tone with the attacks, all right? So we see that. And many people with migraine will get nasal congestion as part of this process. They get a stuffy nose. Now the thing about it is, if you squirt a little sumatriptan up that nose, the headache goes away and their nose clears up and looks perfectly normal. But it also will happen using decongestant medications for some patients. And so they get misled into thinking it's a sinus condition when they take pseudoephedrine and their headache gets better. So pseudoephedrine works to constrict blood vessels, okay? It's also active on other neurotransmitter sites in the central nervous system. It's not just working here in the nose, it works everywhere. So that's why it can be helpful. In fact, there's an old drug that probably very few of you remember or know about. It's a drug called isometheptane mucate or Midrin. That's in your Wayback Machine. Been around for treating migraines since the early 60s, and it is a sympathomimetic in its pharmacologic action. And it works as well as taking a sumatriptan tablet, but it doesn't have any of the cardiovascular downstream effects that we worry about sometimes. Unfortunately, one of the things that does happen in migraine, and it probably occurs because of shared biology involving genetic factors, but we see a higher likelihood of patients with migraine and other frequent headaches having associated mood disturbances. Now, most people who develop depressive symptoms as part of their headache picture aren't going to be jumping off the nearest bridge. They aren't that depressed, but they just have that really dysphoric, sad mood about them and lack of energy. They don't score real high on PHQ screening tools. Similarly, like with anxiety, most of them aren't crawling out of their skin, but there are a few. Most of them are just mildly anxious, stressed people. So we do need to make sure we address the behavioral side in many of these patients when we see it as a component of their headache situation. Now I want to show you an example of why your short hairs go up when things are outside the norm, all right? This is a woman who has a history of developing a scintillating scotoma, okay? So she's got all these bright things going on, okay? You know, it's blocking part of her field of vision, okay? And it's the entire right hemifield. It's fixed. It's the entire right hemifield. Not expanding, it's just sitting there, right? And it's been going on for 2 days. I talked about auras lasting up to an hour, all right? Short hair should be going up. She has a history of having had a visual scotoma with her headache attacks in the past, you know, and typical migraine headaches, but they were short and all, never a big deal. Nothing that stood out from the norm that we would expect. It would last 20 minutes in the past. Now, historically, she's also on hormone replacement therapy, and on ophthalmologic examination, she's got nothing over here. You know, you poke your finger out from the right side, and she doesn't see it coming at her, okay? Vision is gone. You do a workup, everything looks pretty good, except that she blew her ANA right through the ceiling, 8.7. But everything else looks good. So you end up doing angiography on her, and she has managed to occlude off in a couple of spots. Probably a small stroke, probably related to the estrogens, but also it could be related to her autoimmune disease, potentially, if she does have one. She did get better, she did not recover sight. So there are things that can cause what look like auras but aren't auras, okay? And they are outside the norm in that they are long, they are truly hemianoptic, they don't move, they come on suddenly, and the headache itself isn't really tied to the aura. So that's when you want to be suspicious. In the emergency room, more commonly than in the office setting, you know, you have patients come in, they tell you, this is the worst headache of my life. And so the next step is a CAT scan to make sure they don't have a subarachnoid hemorrhage, you know, or a big brain tumor that's going to, you know, fall down through their posterior fossa as soon as you tap them. And then you do a lumbar puncture on them. So there are a few times when you want to do a lumbar puncture. You got somebody who doesn't really have a history of headaches or has a unique headache come on that literally is like a thunderclap. Bang. The headache lasts moments. Not necessarily seconds, but moments. It's gone within a few minutes, all right? It comes out of nowhere and it's different from anything else they've had and there's nothing else. Here and it's gone. That's called a thunderclap headache. That is considered a potential precursor to rupture of aneurysm. So you want to be suspicious on this. You will also see it when there's some of the encephalopathies related to reversible vasoconstriction. You have a headache that's progressing, you have a headache associated with acute illness, or you suspect that there is either too much pressure to the tumor or too low pressure, they got a leak someplace, right? The big problem is that there are all kinds of false positives and false negatives, so you don't want to just tap everybody. You know, not only do you get trauma from it and risk of infection, but then you can develop low spinal fluid pressure headache from the tap, and it stays to clear up. You know, and then you also sometimes get steered down the wrong pathway diagnostically. Cluster headache is the last of the primary headache disorders. It's the rarest of them, occurs in probably less than 1% of the population. And instead of a mnemonic, we're going to give you a visual mnemonic for this. because cluster headaches occur in a bunch. You get a whole bunch of headaches in a relatively defined period of time, and these headaches occur at the same time of day, every day when they're having this bunch of headaches, and they usually occur at the same time of year in a given individual from series to series. So that really distinguishes. The pain is usually around the eye, temporal, it's a more burning, lancinating pain, and they get autonomic symptoms, cranial autonomic symptoms. They get a Horner syndrome, they get a stuffy runny nose, they sweat when they have the headache. The pain is intense. The pain of migraine, or migraine sufferers when they have their pain, even when it's bad, go to bed. They lie still, quiet, all right? A cluster sufferer's headache will get worse doing that. They will be up, they will be around, they will pace, they will rant, they will rave. You get worried about them if they have guns in the house, okay? Because they will threaten to do themselves in, all right? It's a very intense pain, but it's gone in 15 minutes to an hour. As fast as it comes, it goes. Now, we do see a Horner syndrome with it, and there's some things to note about Horner syndrome here. So in cluster headache, because of how the Horner's develops neurologically, not only does the upper lid fall down upon the limbus, but the lower lid comes up. Notice that? And you also notice that there's a myotic pupil. You can't see the conjunctival injection very well, but it is there on that side. So that's what we see when you have a Horner syndrome related to cluster headache. But if you have a carotid dissection, your Horner syndrome looks different because it's occurring through a different neurological mechanism. So you get the droop of the lid, the myotic pupil, but look at the lower lid. It doesn't come up. It doesn't droop. So when the lower lid droops, it goes up, okay? You gotta think about that a little bit. So that lid is not drooped. And that's what you see in carotid dissection. It can be very helpful on examination to differentiate. There can be organic causes of headache. Giant cell arteritis is a headache of the elderly beyond age 50. They have a dilated sore temporal artery. They have a high center rate. It's a unique headache for them. It's a new onset. They oftentimes are medically sick. They may have muscular weakness and soreness being related to coexisting rheumatologic disease. If you suspected, steroids are the treatment of choice. Then you worry about getting the biopsy to confirm the diagnosis. Tumors are rarely causative of headache as the primary presenting symptom. When someone does have a brain tumor that's causing headache, if the tumor is above the tentorium, the headache is directly above the site of the tumor. If the tumor is below the tentorium, it is referred to the occiput. Arthritis of the spine can contribute to headaches because the sensory fibers from C1 through C3 have also connections to the trigeminal nucleus caudalis and the sensory systems there, so you can get referral of pain, get headache as a consequence of nerve root irritation in the upper cervical spine. Anything below C3, you gotta be pretty dubious as a cause of headache from an arthritis point of view. So let's turn to treatment now. Behavioral approaches, biofeedback shouldn't be thrown out with the bathwater. Biofeedback cognitive behavioral therapy are as effective as any of the top tier convention medications. Certainly have a role. They take time to learn and master, but they are well suited, and it doesn't make any difference if you have any coexisting psychological issues or not. Well suited for those who want to avoid medications, especially for younger patients. From about age 10 and up, kids are able to master biofeedback techniques. Treating migraine acutely. The drugs of choice are the triptans in general, okay? All the triptans work basically equally as well. They differ a little bit in the time of onset, their duration of activity, and individual differences in how likely they are to have side effects. There are injectable forms and nasal spray forms of sumatriptan, which are suited for those who need to be treated early because of early onset of nausea with a non-oral medication. There's a nasal spray of zomatriptan, but the rest are all traditional oral tablets. Triptans work best when they're taken in the early stage of migraine. We have a window of time of about 2 hours from the onset of pain to use a triptan to be able to get about a 95% chance of stopping the headache completely within the first 2 hours after that. Any time beyond 2 hours of taking the medication, the patient likely will have improvement, but likely won't lose their headache completely. And so people sometimes hold back because they're afraid it's not a big migraine, they get other headaches, they're afraid they're going to run out of the triptan. You got to give them reassurance, make sure they have adequate supplies. You know, you can buy sumatriptan tablets generically in some pharmacies, cash, for $2. So you don't have to worry about insurance in some situations. But again, really important. The other thing is that the earlier the headache you treat with a triptan, the less likely you are to have side effects from it. So all the side effect complaints people see are because people delay treating, and this nervous system that's hypervigilant, hypersensitive, cranks up, and that's why they get the side effects from it. Chest pain, those kind of issues are probably non-cardiac in origin based upon some of the work we've done with other triptan-related molecules that didn't work on blood vessels at all, and from work in the catheterization lab that shows that you can squirt sumatriptan intraarterially into the coronary arteries and produce less than a 5% change in artery diameter, okay? So probably not coronary in most cases, the chest pain. Some non-steroidals can be a very effective tool. There's a powder form of diclofenac, which is approved by the FDA, and its results are approximately the same as that for oral sumatriptan. Works through a different mechanism, low GI issues because it's already in solution. It's a branded product, but there's pretty good copay coverage from the manufacturer. Naproxen is an interesting one. We did a study with naproxen in patients who had chronic migraine, headaches more days than not. And they were taking hodgepodge of acute medications. We took them off all that hodgepodge. We just had them treated with naproxen sodium 550 twice a day as needed, all right? Over the course of 3 months, 60% of them went from having migraines more days than not to less than 6 days a month of headache. And we did nothing else different. So sometimes some of the non-steroidals that get into the system faster, like naproxen, have longer staying power, can provide some special benefit in those patients who have frequent headaches or they can't take a triptan medication. You want to avoid opioids for all the reasons you can think of, plus one more. Taking opioids, even sporadically for migraine, can change the pain operating system in such a way that triptans no longer will provide complete relief of the migraine. You lose the effect of other drugs. Barbiturates, everybody's favorite, Fioricet. We'll go with a brand for this one because it's everybody's favorite. Everybody loves Fioricet. And it's a great drug. Okay? Problem is that once you get beyond about 6 days a month of using a butalbital-containing analgesics, you have a very high likelihood of going into what's called rebound, literally a drug-induced headache. Whereas with other analgesics or triptans, you're talking 12, 14, 15 days a month. Even opiates, you need 10 days a month of regular use to convert. Butalbital, not so much. So why do patients overuse medications? Well, they get frequent headaches. That's the biggest reason. But for a lot of the analgesics, the opioids, the butalbitals, why do they take it? Because you are also treating underlying psychological issues. You know, butalbital is a tranquilizer. Opiates quiet the nervous system. So sometimes patients take these drugs because they make them feel good behaviorally. In using preventive medications, because you're dealing with patients who have a sensitive system, you have to take the approach of start low, go slow, and building up the dose. So in going slow, I'm talking no more than about 4 weeks to get to a good therapeutic dose, all right? And so you start with a small dose, 25 of topiramate once a day at bedtime. You get up to 100 milligrams by the end of the first month, okay? That's a good approach. It minimizes the side effect burden for these patients, but then you also have to give them an adequate trial on it. Preventive medicines for migraine almost always take 4 to 8 weeks to really start working. You usually give it 12 weeks, ideally, if there's any response at all, and you may need to adjust the dose if they tolerate it. But you always want to consider adequate trial. I have patients come in who tell me, well, I've been on all the top tier drugs, doc, for my headaches. Well, how long were you on amitriptyline? 2 weeks. How much did you take? 10 milligrams. Okay? Well, that's nothing times nothing is nothing. Okay? Obviously, it doesn't work in this situation. One of the quandaries about overuse of analgesics is that it can block the ability to see or get a response with prevention medication. So sometimes you got to take them off their offending meds while starting on prevention. Nobody wants to take drugs for the rest of their life in most cases, so if someone's got good control on their migraines for 6 months to a year, you got a pretty good chance of being able to stop at that point without major recurrence. If headaches do come back frequently, put them back on for another 6 months to a year. Kind of use the same analytic approach that you would use in treating a major depression. You know, people get better with depression, you take them off their drugs, but if they fail 3 times, they have to stay on antidepressants for the rest of their lives. Same kind of thing in treating migraine. A good source of information, good evidence-based approach, are the guidelines that were published in the Academy of Neurology in 2012. Now, I'm biased, I helped write them. I also helped write the 2000 ones, okay? But they are really good evidence-based approaches. They provide solid evidence. And for patients being treated in primary care, I usually recommend that you don't stray much beyond the tier A drugs. So the beta blockers such as propranolol, metoprolol, the anti-epileptics such as topiramate and divalproex, the herbal therapy pedonolix, magnesium. You want to keep it to those level ones. You don't want to get way off the track and start prescribing memantine for migraine headache, okay? Because there's very poor evidence, and you know, you really probably should have considered better options first before you get there. So you want to keep top tier evidence in mind when choosing medications. So strategy, make sure you have good acute attack management. If the attacks are starting to increase in frequency or are occurring frequently, you want to address issues that can cause migraine to become more frequent. So that's where diary keeping, lifestyle modification comes in, optimal control of the acute attacks, and then trying to address any coexisting issues that are associated with, so the mood issues, the obesity issues, the sleep disorders, that all drive migraine becoming more frequent, then optimal management of their prevention medications. Because as migraine progresses, you will see progression of other associated disease states with this. And so they get sleep disorders, and they get GI complaints, and they get fibromyalgia, and then they get mood depression issues. But one of the things that really stands out about this is, let's look what happens. In typical episodic migraine, you get an attack, your nervous system gets all a joint, but it comes back to a complete state of normalcy. And as long as the attacks are sporadic, everything comes back to being normal. Now, if the attacks start to become too frequent, you get the attack, you get all out of joint, but your nervous system never gets all the way back to normal, okay? It's always disrupted, it's always on edge. Next attack occurs, and pretty soon, you're not getting anywhere close to being normal anymore. Your nervous system is always disrupted neurologically, physiologically, making you prone to development of the headaches and the other disease states. So what are the risk factors for this headache development that you should be on guard for? Some you can change, some you can't, okay? We can change attack frequency. That's where prevention comes into play. Address weight. Now, I'm the kettle calling the pot black, okay, when it comes to weight, but obesity is a major factor driving headache. In morbidly obese patients who undergo weight loss surgery, losing as little as 10% of their body weight can produce upwards of a 50% reduction in their migraine days with nothing else being done, okay? So weight does play a role. Overuse of the acute medications, learning how to manage stress, sleep, really important, okay? Disrupted sleep, sleep disorders, sleep apnea, restless leg syndrome, address those issues as best as you can. Give everybody a good sheet on sleep hygiene. It's amazing how many people, watch TV in bed, play games in bed on their internet, have their phone plugged into their ear when they go to bed, and they wonder why they don't sleep, okay? Can't do it, too much stimulation. Chronic migraine is when people progress to having migraine on a near daily basis. The one thing that differentiates them treatment-wise from episodic migraine is that onabotulinum toxinate, better known as Botox, is effective as a prevention treatment. It's not effective in episodic migraine when you're only getting like 8 migraines a month. But for almost daily headache, it's the most effective of the therapies. We also have evidence for a few other things, and again, because the best prevention medications only get rid of 50% of the headaches in 50% of the patients, you oftentimes need to use several different levels of care here in these patients who are having headaches daily or nearly every day. Now, in the coming months, you're going to be hearing more and more about CGRP, calcitonin gene-related peptide. It's a neuropeptide that is released as part of the migraine attack. It plays a role in modulating pain and modulating the inflammatory response around the blood vessels. And we've known about it for a long time, and we have tried developing drugs to block it as it's released, and they haven't worked out real well, but there's a few still in the pipeline. But what we have developed, and it grows out of all the work being done elsewhere in medicine, is antibodies that block the CGRP chemical. And they do a remarkably effective job, it appears, with very good tolerance from the studies. And in a goodly share of patients, from the first injection, you never have another headache, period. From the first injection, first day, that's it, okay? So, they look to be extremely promising. Of course, we're waiting for the other shoe to drop once they get into clinical practice, but look extremely promising. God knows what they're going to charge for them. Don't even get me going on that. God knows how the insurance companies are going to pay for them. Don't get me going on that. But very promising new field of effort. Cluster headache. You can use triptans for treating cluster headache, but you have to have something that works real fast. So you usually need an injection or a nasal spray. But the best is oxygen. Big drawback to oxygen is nobody wants to pay for it. But 100% O2 via face mask, non-rebreathing face mask, 10 minutes, boom, stop, almost everybody. Only thing dangerous about it is if you smoke around it. So, good choice, but you gotta get a source for it, and it has to be a high enough flow. Verapamil, a calcium channel blocker, is very effective for treating cluster headache. It doesn't do much in migraine, okay? But it's the go-to drug for cluster headache. And if you really want to be on that pedestal, the god of your patients, okay, is you give them a short course of a healthy dose of a corticosteroid at the start of their cluster cycle. Because within 24 hours of starting a steroid, their headaches stop. Cold. Fortunately, if you only give them steroids, they'll come back. So that's why you have to throw the verapamil into the mix. But it just stops the process cold in its tracks. You don't keep them on for a long time, week, 2 weeks at the most. With a short course of steroids, rapidly taper them down. There are other things that have been done for cluster headache, especially for the more chronic ones. Again, this should be probably reserved for people who treat cluster headache on a regular basis. Tension headache, muscle relaxants, simple analgesics. Now, we also use antidepressants in these people regardless of whether there's any underlying mood disturbance, because the older tricyclic antidepressants and some of the SNRI agents have effects on modulating the neurotransmitter systems in the trigeminal nucleus, and by doing that, they help stop the pain. You can divide tension headache into 2 groups. One where there's pericranial muscle tenderness. So these people come in, you examine them, and their scalp is sore, their neck is sore to touch, all right? They're peripherally acting agents, muscle relaxants, physical modalities, very useful. You get others who come in, their scalp isn't sore, their neck isn't sore, but they have a killer headache all the time, 24/7. Peripherally acting agents won't work there. That's where the antidepressant drugs come into play. So those are the choices for most patients. So we've covered a lot of ground, a lot of different medications, a lot of ideas to think about patients. Hopefully this makes some reasonable level of sense for you. And with that, before you throw me out the door, thank you very much. I'll be happy to entertain anyone's questions.
What's been your experience with Botox?
Botox is by far and away the most effective medicine we have for treating very frequent migraine. By far and away. I've been doing Botox since 1995. Okay? You have to use the protocol, okay, because we showed that lower doses of Botox or more selective injections really don't get the job done very well in headache, all right? It doesn't tend to work very well in cluster headache or neuralgia. People have tried it, and it doesn't work in tension headache. Even if you have peripheral muscular complex, it really doesn't do a very good job. It's very well tolerated, it's just expensive. For Botox? 155 units, 31 locations. 31 locations. 3 here, 4 forehead, 4 temple, 5 occipital, 3 in the traps.
Okay. Well, we do it in our office. We do it. We do it on the 31.
Well, that's fine. That's your, good luck getting it covered, paid for and all that kind of stuff,
Usually we'll do like 50 at Mexico, but do you like
Oh, yes.
Yeah.
Because when we did the clinical trials, we did like 10,000 patients in clinical trials with every possible combination of dosages and location that you can imagine, all right? We showed leaving those out, cut efficacy. That's why we're at 31, because we did buku patients, okay? And yeah, there are some people we can do a modified follow the pain if they don't get a great response with the standard protocol where you give them some extra. But by far and away, there's, if you stick to the protocol, you're going to get it. But if you got an alternative protocol that works for your folks, that's great. My biggest issue that I have with that is that we have insurance companies who turn us down for repeat injections, for repeat prior authorizations, when we stray from protocol.
Right.
So, I think the wholesale price of 100 units of Botox is about $700 nowadays, maybe $800. So about $1,600 for a treatment. Every 12 weeks. Insurance companies cover the vast majority of it. The manufacturer provides $1,200 a year of copay assistance. The only people who don't get coverage on that are going to be Medicare and Medicaid.
Thank you.
Other questions? Thank you so very much for coming today.
Thank you.